Hello everyone, this is Dr. Shivangi and today we will discuss one topic that is intrauterine adhesions and their evaluation. So let's just start the topic. So today I'll be covering this topic under the heading of definition, its prevalence, its etiopathogenesis, its clinical presentation, diagnostic evaluation, classifications of intrauterine adhesions, management and prevention of recurrent adhesions. So, what is intrauterine adhesions? See, this is the uterus. This is a normal uterus, and these are the bands of fibrous tissue within the endometrial cavity. So, these are intrauterine adhesions. So, intrauterine adhesions are the bands of fibrous tissue that form in the endometrial cavity, and they often are a response to a uterine procedure. तो कोई भी हमने uterine procedure किया उसकी वजह से जो bands of fibrous tissue that forms in the endometrial cavity is known as intrauterine adhesions. And whenever these intrauterine adhesions, they present with some symptoms like infertility or amenorrhea, then we call it as Asherman syndrome or amenorrhea traumatica. There are two types of intrauterine adhesions. They are primary and secondary. Primary जो होते हैं वो after pregnancy related curettage और after hysteroscopic surgery. मतलब हमने कोई primary surgery करी उसके बाद जो intrauterine adhesions हैं that are primary. बट अगर सर्जरी करने के बाद अगर वो रीअकर कर रहे हैं दैट आर नोन एज सेकेंडरी इंट्रायूटाइन एडेशंस. Its prevalence, so it is impossible to detect or estimate the true prevalence of intrauterine adhesions because most cases they are without symptoms. Its prevalence range from 1.5% as an incidental finding at HSG. Suppose हमने HSG कराया उसमें हमें intrauterine adhesions मिल गए and to 21.5% of women with a history of postpartum uterine curettage. And postpartum uterine curettage is the most common cause of intrauterine adhesions. More than 90% of cases occur after pregnancy related curettage. Now, if we talk about its etiology, see, uterine layers. From outside to inside, they are perimetrium, then myometrium, then endometrium. Endometrium has two layers, basalis, then functionalis. This functionalis layer, जब भी menses होते हैं तो functionalis layer shed off हो जाती है, but ये basalis layer intact रहती है. बट अगर कोई विग्रस क्यूरेटाज करते हैं तो आफ्टर विग्रस क्यूरेटाज जो बिसैलिस लेयर होती है वो डैमेज हो जाती है. तो जब ये बिसैलिस लेयर डैमेज हो जाती है उसकी वजह से जो रिस्पॉन्स होता है कि जब वो हील करती है तो जो अपोजिंग लेयर्स होती हैं जो अपोजिंग लेयर्स है यूट्रस की वो एक बीच में फाइब्रस बैंड बना लेती हैं दैट आर नोन एज इंट्रायूट्राइन एडेशंस. So these intrauterine adhesions they result from trauma to this basalis layer of the endometrium. This basalis layer is most susceptible to damage in the first 4 postpartum or post-abortal weeks. And this VEGF they are important modulators of endometrial stromal fibrosis. VEGF is downregulated in the endometrial tissue of women with Asherman syndrome. Then this subsequent tissue healing on the opposing surfaces of the uterus, they eventually fuse to produce tissue bridges. These intrauterine adhesions, they may be flimsy adhesions that are composed of endometrial tissue, and they can be dense adhesions that are composed entirely of connective tissue. If we talk about etiology, that either trauma to the gravid uterus or non-gravid uterus. Trauma to the gravid uterus causes are postpartum curettage, most common cause, post-abortal curettage, after cesarean section, molar evacuation, B-Lynch procedure. In trauma to non-gravid uterus, these are after diagnostic curettage, IUCD insertion, uterine artery embolization, uterine devascularization in PPH. After any infection or endometritis, example TB, congenital uterine anomalies, example septate uterus, genetic predisposition, after hysteroscopic surgeries like after myomectomy, septoplasty, polypectomy, endometrial ablation, and it can occur after abdominal myomectomy as well. If we talk about the clinical presentation, तो mostly ये जो patients होते हैं, they present with oligomenorrhea, hypomenorrhea, or secondary amenorrhea, irregular menstrual cycles, painful menstrual periods. They present with cyclic pelvic pain. They present with infertility, repeated miscarriages or pregnancy losses, pelvic pain, especially during menses or sexual intercourse, AUB. So, Why these patients present like this? So why cyclic pelvic pain occurs? Now, if we see, because of these fibrous tissue bands in the endometrial cavity, there is a block in the outflow of the menstrual blood. So whenever there is a time of menses, out there is a block in the outflow of the menstrual blood, तो वो जो blood जो collect हो रहा है, that is causing cyclic pelvic pain that leads to uterine cramping, pelvic discomfort और pain. नेक्स्ट थिंग इज कि जो स्कार टिश्यू हो रहा है, उस वो क्या करता है, जो नॉर्मल एंडोमेट्रियम है उसको रिप्लेस कर देता है। तो जो नॉर्मल एंडोमेट्रियम है वो कम रह गई है, देयर इज अ लेस एंडोमेट्रियम टू बी शेड ड्यूरिंग मेंसेस। इसकी वजह से पेशेंट को हाइपोमेनोरिया और कभी कभी एमेनोरिया भी होता है। और ये कभी कभी आउटफ्लो ऑफ द मेंस्ट्रुअल ब्लड भी ब्लॉक कर देता है ये स्कार टिश्यू, जिसकी वजह से पेशेंट को ब्लड कलेक्ट हो जाता है, हेमाटोमेट्रा हेमाटोसेल्पिंग्स होता है। समटाइम्स इनफर्टिलिटी होती है, इनफर्टिलिटी बिकॉज ऑफ ये जो बैंड्स हैं, दे कैन कॉज ऑब्स्ट्रक्शन ऑफ द ट्यूबल ऑस्टिया और ब्लॉक ऑब्स्ट्रक्शन ऑफ द एंडोसर्विक्स दैट कैन लीड टू इनफर्टिलिटी। Now, if we look at the clinico-pathological correlation, जो patient की जो clinical features हैं, they are closely associated with the pathological findings in Asherman syndrome. मतलब जो pathological finding होगी उसके according ही patient की clinical features रहते हैं, mostly correlate करते हैं। ये जो pathological findings है, they are dependent on, they are like डेप्थ ऑफ फाइब्रोसिस कितनी है, लोकेशन ऑफ एडिशंस का एंड एक्सटेंट ऑफ द पैथोलॉजिक चेंजेस की कितने पैथोलॉजिक चेंजेस है। नाउ सपोज पेशेंट को इंट्रायूट्राइन फाइब्रोसिस है विदाउट विजिबल एडहेजन और ऑब्लिटरेशन ऑफ कैविटी, लाइक मतलब सिर्फ यूट्रस में फाइब्रोसिस है बट आपको कोई एडहेजन्स विजिबल नहीं है, कोई ऑब्लिटरेशन नहीं है कैविटी का, तो वेरिएबल प्रेजेंटेशन होगा पेशेंट का। बट सपोज पेशेंट को सर्वाइकल कनाल एडहेजन्स है, तो अगर सर्वाइकल कनाल एडहेजन्स है तो यहाँ पे है, तो जो ब्लड है बाहर नहीं जा पाएगा, तो इसकी वजह से ऑब्स्ट्रक्टिव एमिनोरिया होगा। सपोज यूट्राइन कैविटी एडेशंस है, तो अगर सेंट्रल एडेशंस है विदाउट ऑब्लिटरेशन ऑफ द कैविटी तो वेरिएबल प्रेजेंटेशन रहेगी। अगर यूट्राइन कैविटी पार्शियली ऑब्लिटरेटेड है एंड कंस्ट्रिक्शन ऑफ द कैविटी हो गई है, या फिर कंप्लीट ऑब्लिटरेशन ऑफ द होल यूट्राइन कैविटी हो गई है, तो पेशेंट प्रेजेंट्स विद एमिनोरिया एंड इनफर्टिलिटी। अगर यूट्राइन कैविटी कंबाइंड विद सर्वाइकल कनाल एडेशन है तो सेम ऑब्स्ट्रक्टिव एमिनोरिया की तरह प्रेजेंट करेगी पेशेंट। Now, how to diagnose such patients? Diagnostic evaluation. First thing is always history. In history, we have to ask her menstrual symptoms, like patient will present with hypomenorrhea, oligomenorrhea, secondary amenorrhea, and we have to ask about and previous pregnancies, about the previous intrauterine procedure history. Then we have to do the physical examination. Usually, physical examination normal रहता है ऐसे patients में। Blind transcervical uterine sounding may reveal cervical obstruction at or near the level of the cervical os. But ये बहुत पुराने procedures हैं. Nowadays, we are not doing any blind procedures. Adhesions that are higher in the cavity or more laterally may not be demonstrated in this manner. But yes, obviously, आजकल nobody is doing this blind transcervical uterine sounding. Now, suppose HSG is not recommended in Asherman syndrome to diagnose, but suppose हमने HSG कराया, उसमें इस तरीके की पिक्चर दिख रही है, तो क्या मिलते हैं एशरमैन सिंड्रोम में? मल्टीपल irregular linear filling defects may give a lacunar pattern with the inability to appropriately distend the endometrial cavity. मतलब multiple irregular linear filling defects मिलते हैं और पूरी endometrial cavity distend नहीं हो पाती है। Severe cases में there can be even complete non-filling of the uterine cavity. Advantages of HSG are it provides information about the fallopian tubes as well, and it is less costly. Disadvantages, it's low sensitivity, 75 to 81%, high false negative rates of 39%, patient discomfort, risk of exposure to radiation. Next is SHG, that is sonohystrography. Sonohystrography, it's an ultrasound procedure where the saline, gel, or foam is instilled into the uterine cavity via cervix. This is also known as saline infusion sonography, saline infusion sonohystrography. If we are using gel, then gel infusion sonography. If we are instilling foam, then foam infusion sonography. एंड जैसे सपोज हमने सलाइन इन्फ्यूजन सोनोग्राफी किया, जैसे हम इसमें सलाइन डालेंगे, इस तरीके की फिलिंग डिफेक्ट्स, इस तरीके के बेंड्स टाइप दिखते हैं दैट इन एसआईएस लाइक दिस। एंडोमेट्रियल कैविटी में देखिए बैंड्स दिखते हैं, दैट इज डायग्नोस्टिक ऑफ एशरमैन सिंड्रोम. So when uterine distension media like saline, sonostogram, gel infusion, ultrasound, foam ultrasound is used during assessment, its diagnostic accuracy increases to roughly 75%. Its pooled sensitivity and specificity reached 82 and 99% respectively. Next comes 2D ultrasound that we are doing on our regular practice. In 2D ultrasound, see, what we can find is this interrupted endometrial line in sagittal plane. तो sagittal plane में देखेंगे तो आपको interrupted endometrial line मिलेगी, punctate ecogenic foci in the endometrium, indistinct endomyometrial junction मिलेगा, indistinct endometrium, a very thin endometrium less than 6 mm that doesn't increase even with the hormonal therapy. आप कितना भी एस्ट्रोजन दे दो उसकी endometrium increase ही नहीं कर रही है despite normal ovaries, normal hormone profile. Then what we can found is endometrial fluid we can found in the endometrial cavity, commonly loculated appearing as small focal cystic areas within the endometrium. Sometimes what we can found is hyperechoic lesion without posterior shadowing that reflects fibrosis, and if with posterior shadowing, it reflects calcifications. Next comes the role of 3D transvaginal ultrasound. In 3D transvaginal ultrasound, what we can find is irregular endometrial cavity outline in coronal plane. तो endometrial cavity की outline will be irregular. Decreased endometrial thickness, कभी कभी less than 2 mm मिलती है. Interrupted endometrial line, undetectable endometrium. If there is extensive adhesions, then undetectable endometrium. The narrowing of the endometrial cavity, that is transcornual diameter of less than 20 mm and mid cavity diameter of less than 10 mm. नेक्स्ट इज डायग्नोस्टिक इज हिस्ट्रोस्कोपी. तो जब भी हम हिस्ट्रोस्कोपी करते हैं उससे हम इट्स अ डायग्नोस्टिक, इट्स अ गोल्ड स्टैंडर्ड. हिस्ट्रोस्कोपी इज द गोल्ड स्टैंडर्ड टू डायग्नोस intrauterine adhesions, Asherman syndrome. It more accurately confirms the presence, its extent, and morphological characteristics and the quality of the endometrium. It provides a real-time view of the cavity that enables us to accurately do the description of its location, degree of adhesions, its classification, concurrent treatment of intrauterine adhesions. There are several classification systems that are based on hysteroscopic findings. So these are the hysteroscopic pictures. This first picture, it is showing normal cavity. The second picture, it is showing mucosal adhesions. Mucosal adhesions are usually pink in color. They're like the surrounding endometrium, and yes, they are easy to lyse. This is showing fibromuscular adhesions. They are very thick, wide band, and they are difficult to lyse. So classification of intrauterine adhesions. There are many classifications of intrauterine adhesions. AAGL, in collaboration with SJ, in 2017, they formulated the following guidelines on intrauterine adhesions. And these are: intrauterine adhesions should be classified as prognosis is correlated with severity of adhesions. This is level B. Then various classification systems make comparison between studies difficult to interpret. This may reflect inherent deficiencies in each of the classification systems. Consequently, it is currently not possible to endorse any specific system. Level C. तो इतने सारे classification systems हैं intrauterine adhesions के कि कोई मतलब एक स्टडी, इट्स नॉट लाइक कि एक ये स्टडी है, मतलब एक ये क्लासिफिकेशन सिस्टम वी आर गोइंग टू यूज. बट जो मोस्ट कॉमनली क्लासिफिकेशन सिस्टम जो हम यूज करते हैं, सी this many classification systems are there for intrauterine adhesions. So most commonly what we are using, that only we'll discuss. First is most commonly this is used, that is American AFS classification 1988, and this is based on extent of cavity involved, type of adhesions, and menstrual pattern. मतलब कितना, फर्स्ट इज कितनी कैविटी इन्वॉल्व है, इज इट 1/3 इन्वॉल्व, 1/3 to 2/3 involved, more than 2/3 involved. Score is 1 to 4. Then type of adhesions, flimsy adhesions है, बीच में flimsy and dense 1 to 4. Menstrual pattern, normal, hypomenorrhea, amenorrhea 0 to 4. So 1 to 4, 1 to 4, 0 to 4. Then stages, stage 1 mild, stage 2 moderate, stage 3 severe. Stage 1 is 1 to 4, stage 2 का score is 5 to 8, and stage 3 is severe, that is 9 to 12. 1 to 4, 5 to 8, 9 to 12. This is SJ classification 1995. This some people use this classification also. One is thin or flimsy adhesions. Second is singular dense adhesions. 2A is occluding adhesions only in the region of the internal cervical os. 3 is multiple dense adhesions. 4 is extensive dense adhesions with partial occlusion of the uterine cavity. 5 is extensive endometrial scarring and fibrosis in combination with grade 1 or grade 2 adhesions. 5B is extensive endometrial scarring and fibrosis. Now, moving towards the management of intrauterine adhesions, aim. Our main aim of management is we have to restore the uterine cavity. हमें पूरे uterine cavity को पहले की तरह कर, पहले की तरह तो we can't do, but maximum जितना हो सके we have to restore the uterine cavity. We have to prevent its recurrence. We have to do the endometrial restoration, and we have to maintain that normal cavity. So, treatment options. What are the treatment options available? We can do expectant management, cervical probing, dilatation and curettage, hysteroscopy gold standard, laparotomy or hysterotomy. These expectant management, cervical probing, DNC, they are old. Now we are not using these things. What we are using is hysteroscopic adhesiolysis. That only we are doing. That is a gold standard. If it is difficult, not possible, then only some people are going for laparotomy. Otherwise, hysteroscopic adhesiolysis is okay. Hysteroscopic adhesiolysis. What we do is it enables the lysis of intrauterine adhesions under direct vision and with magnification. The uterine distension required for hysteroscopy, sometimes it may itself lyse mild adhesions. बहुत फ्लिम्सी adhesions जो होते हैं ना, तो जब नॉर्मल सलाइन जब प्रेशर से जाता है ना अंदर, sometimes it may itself lyse mild adhesions. Surgical treatment may also take place in an office or outpatient setting with outcomes similar to those in an inpatient setting. So, hysteroscopic adhesiolysis methods क्या available हैं? We can do it by scissors, we can do it by monopolar or bipolar electrosurgical instruments, or we can use Nd:YAG laser. This picture it is showing this, we are using scissor in that, right? This picture showing. So, first is hysteroscopic scissors. What we can use is semi-rigid 5 French or 7 French scissors through a 6.5 mm operating hysteroscope is the preferred method for resection of intrauterine adhesions. What are its advantage? कि जब हम उसको कट कर रहे हैं, लाइस कट कर रहे हैं एडेशंस को, तो एडवांटेज क्या होता है? इफ देयर इज अ स्लाइट ब्लीडिंग एट द फंडस, देन इट इंडिकेट्स दैट वी आर एंटरिंग इनटू द मायोमेट्रियम. तो अगर थोड़ी सी भी ब्लीडिंग हो रही है, तो उसका मतलब है वी आर एंटरिंग इनटू द मायोमेट्रियम. एंड एडिक्वेट एडहेसियोलिसिस, a phenomena that is masked if instruments with coagulation capacity are used. That is, suppose हम scissor यूज कर रहे हैं, तो जब तक हम adhesions को कट करेंगे ब्लीडिंग नहीं होगा. लेकिन जैसे ही हम नॉर्मल मायोमेट्रियम पे पहुंचेंगे, मायोमेट्रियम कट करने लगेंगे, तो ब्लीडिंग होने लगेगी. तो हमें पता चल जाएगा कि यस, एडिक्वेट एडहेसियोलिसिस इज कंप्लीट. बट सपोज अगर हम इंस्ट्रूमेंट जिनमें विद कोएगुलेशन अगर हम यूज कर रहे हैं, तो ऑलरेडी कोएगुलेट करता हुआ चलता है, तो हमें पता ही नहीं चलेगा कि ब्लीडिंग वाला पार्ट आएगा ही नहीं, तो हमको पता नहीं चलेगा. इसलिए दैट्स व्हाई सिजर्स आर बेस्ट. दिस इज शोइंग हिस्टोस्कोपिक सिजर्स. Next is monopolar electrosurgery instruments. Its advantages are it's very precise. There is hemostatic resection of disease, but its disadvantages are it require non-electrolyte distending media like glycine, sorbitol, hypotonic solutions. They can cause hypoosmolality, hyponatremia, and deadly cerebral edema with brainstem herniation if excessive absorbed. There is increased risk of visceral damage if uterine perforation occurs while using monopolar instrument. Endometrial damage जो होता है from these instruments, they may predispose it for the recurrence of the intrauterine adhesions. Next is bipolar electrosurgery instrument. Some people use this also. Its advantages are like monopolar instrument may we have to use glycine, sorbitol, but in bipolar we can use normal saline, which is an isotonic solution as the uterine distension media. Then fluid deficit का जो level है, that is also high, that is at 2.5 liters. That is easily reversed by Lasix-induced diuresis. But its disadvantages are excessive fluid deficit with normal saline. It can result in hypervolemia, pulmonary edema, and congestive heart failure. There is increased risk of visceral damage. Endometrial damage from these instruments, they may predispose for the recurrence of intrauterine adhesions. Next is Nd:YAG laser. It can be used to assist with hysteroscopic lysis of intrauterine adhesions. The use of laser That is for precise location, but there is a significant risk for injury. Best is scissors, but अगर बहुत ही thick adhesions हैं, then only we have to use these uh, cauteries and all, bipolar surgical instruments. So, what are the important differences between hysteroscopic scissors and electrocautery? Cautery ज्यादा डैमेज कराती है टू द एंडोमेट्रियम एज कंपेयर टू द सिजर्स. सेकेंड थिंग, अगर परफोरेशन हो जाता है यूट्रस का, तो सिग्निफिकेंट बावल और यूरिनरी ब्लैडर की इंजरी कॉटरी में ज्यादा है एज कंपेयर टू द सिजर्स. थर्ड थिंग इज, अगर हम रिसेक्टोस्कोप यूज कर रहे हैं तो इट इज मोर एक्सपेंसिव कंपेयर विद सिजर्स. फोर्थ थिंग इज, जो रिसेक्टोस्कोप है वो उसके लिए आपको सर्वाइकल डायलिटेशन पहले करना होगा, जबकि सिजर्स में कोई सर्वाइकल डायलिटेशन की जरूरत नहीं है. 6.5 mm का हिस्ट्रोस्कोप से इजीली 5 इंच 7 इंच के सिजर चले जाते हैं. देन द यूज ऑफ कॉटरी इज हाइवर एसोसिएटेड विद बेटर एबिलिटी टू सिक्योर हीमोस्टेसिस. जो हीमोस्टेसिस है वो ऑब्वियसली कॉटरी से बेटर आती है. नाउ, कभी कभी हिस्ट्रोस्कोपी में हमें गाइडेंस की जरूरत पड़ती है टू प्रिवेंट, मतलब सपोज बहुत ज्यादा थिक एडेशंस हैं, तो हमें कभी कभी एडिशनल टेक्निक्स यूज करनी होती हैं फॉर गाइडेंस ड्यूरिंग हिस्ट्रोस्कोपी. फॉर दिस, फर्स्ट मेथड इज वी कैन यूज मिथिलीन ब्लू डाई. What it does is, when we instill the methylene blue dye, then it stain the endometrium and it guide the surgeon into pockets of island of endometrium in between areas of fibrosis. It is best used in treatment of mild and marginal disease. तो endometrium है वो blue हो जाएगी, pockets of island of endometrium in between areas of fibrosis we can see methylene blue dye देके. Next is, we can do ultrasound guided resection. When we do ultrasound guided dissection, it helps to delineate the location and the extent of the adhesions. It reduces the risk of uterine perforation. But uterine perforation in as many as 5% of cases have been reported, even with ultrasound guided resection. Next is, we can do fluoroscopic guided resection. It allows the surgeon to view islands of endometrium behind scar tissue in an obliterated uterine cavity. Radiopaque dye, it is injected using Tuhoi needle into an area of dense scar at the point where the cavity is obliterated. Any pockets of endometrium beyond the adhesive area can be identified using fluoroscopy, and this area can be opened up by sharp dissection under hysteroscopic view. Next is laparoscopic guided resection. When there is a severe case of intrauterine adhesion, when there is severe intrauterine adhesion, for such cases, for the immediate recognition and treatment of uterine perforation and to minimize extrauterine trauma, this laparoscopic guided resection is done, but it does not decrease the occurrence of uterine perforation. सो हम करते क्या है, हम हिस्ट्रोस्कोपिकली लाइस कर रहे होते हैं एडहेशंस, और लेप्रोस्कोपिकली पोर्ट से देख रहे होते हैं यूट्रस को. तो जब ये रेड लाइट दिखने लगती है, तो इसका मतलब है कि हमारा, मतलब एडहेशन कंप्लीट हो गया है और मायोमेट्रियम के बहुत क्लोज है. तो अगर हम इससे ज्यादा करेंगे तो इसमें रिस्क ऑफ यूट्राइन परफोरेशन है. दैट इज नोन एज ग्लो साइन. GLOW, glow sign. Laparoscopic guidance for Asherman syndrome surgery. Glow sign. Next is prevention of recurrent adhesions. अब सर्जरी हमने कर ली, दोबारा भी adhesions बन सकते हैं, तो उनको कैसे प्रिवेंट करना है? So, because of the high rate of reformation of the adhesions, 3.1 to 23.5%, especially the severe ones, that is 20 to 62.5%, prevention after surgery is essential. The risk is directly correlated with the type and the etiology of adhesions. There is no consensus regarding the optimal methods to prevent intrauterine adhesions. So methods used for prevention are, we can do second or third look hysteroscopic adhesiolysis. There are some barrier method available, that is Sepra film, hyaluronic acid gel, amnion graft. There are mechanical methods available like IUD, lips loop, Foley's balloon. Hormone treatment we can give, that is estrogen, progestin, GnRH analogs, danazol. Pharmacologic agents like antibiotics, NSAIDs, calcium antagonists, antihistaminics, and stem cell treatments. So, prevention of recurrent adhesions. First method is we can do relook hysteroscopy. Early second look hysteroscopic adhesiolysis after primary treatment of intrauterine adhesions. That is an effective method for the maintenance of the cavity as well as the prevention of recurrence. तो हमने एक बार hysteroscopic adhesiolysis किया, उसके बाद early second look hysteroscopic adhesiolysis we can do. It is been in many studies it has been shown that it is that relook hysteroscopy is associated with increased pregnancy and live birth rates when it is performed within 2 weeks to 2 months after surgery. So within 2 weeks to 2 months हमें relook hysteroscopy करके अगर mild adhesions है that we have to remove. These are the hysteroscopic picture. This is showing this healthy endometrium is noted with a small band of scar tissue that is reforming at the fundus, the site where the thick band of scar tissue was removed previously. The hysteroscopic scissors were used to take down adhesions at the fundus with restoration of the anatomy of the cavity. Next is we can use barrier methods. In barrier methods, most commonly available is Sapra film that we can use. It's a bioresorbable membrane of chemically modified hyaluronic acid and carboxymethyl cellulose. It is shown to be effective in reducing adhesion formation, but there are limited evidence that saprafilm was effective in preventing adhesion formation following gynecological surgery for myomectomy. Next is we can use hyalurobarrier gels, ACP gels, that is auto cross-linked hyaluronic acid gel. Hyaluronic acid, it's a natural component of the extracellular matrix and it has been suggested as a possible adhesion barrier. After hysteroscopic adhesiolysis, intracavitary ACP gel application effectively prevents post-operative adhesion formation. And its cost is approximately 3,200, not that costly, we can use. Next is amnion graft. Fresh amnion graft, it is draped over an inflated Foley catheter balloon, and repeat hysteroscopy showed further adhesion formation in 48%, but all these were minimal. So we can use, but long-term data, they are not available. Amnion graft is a promising adjunctive procedure for decreasing recurrence of adhesions and encouraging endometrial regeneration. Next method is we can use mechanical methods. Foley's we can use. Some studies reported that if we apply a 8 to 10 French Foley catheter into the uterine cavity with an inflated balloon for 7 to 10 days after adhesiolysis, it may prevent recurrence. तो जैसे आपने hysteroscopic adhesiolysis किया, आपको 8 to 10 French Foley catheter inflate करके for 7 to 10 days in the uterine cavity छोड़ देना है. Then there are specialized balloon, जिससे ये balloon जो है उसमें ये सर्कल शेप का है, तो कुछ पार्ट जो है एंडोमेट्रियल कैविटी का वो बच जाएगा जो कि फोली बलून ने कवर नहीं किया, वहां पे एडेशंस बन सकते हैं. तो एक स्पेशलाइज्ड बलून्स हैं दैट इज कुक बलून यूट्राइन स्टेंट दैट आर ऑफ शेप ऑफ यूट्राइन एंडोमेट्रियल कैविटी. तो पूरी एंडोमेट्रियल कैविटी को कवर कर लेते हैं जिससे रिस्क रिकरेंस का रिस्क कम हो जाता है. सो अ कुक बलून यूट्राइन स्टेंट इट मेंटेन्स सेपरेशन एट द मार्जिन्स ऑफ द यूट्राइन कैविटी वेयर reformation is most common. They are placed immediately after complete adhesiolysis. The duration that a stent remains in place, it is based upon the extent and the density of the scarring. And a broad spectrum antibiotic is prescribed during the time that the stent is in place. Next is Lippy's loop we can use, but it is not available. Some authors suggest that larger inert devices such as Lippy's loop is effective in the prevention of recurrent adhesions. These copper-bearing IUDs, they might induce an excessive inflammatory reaction, and these T-shaped coils may have a too small surface area to maintain the uterine cavity. So Lippy's loop is not available. These T-shaped coils, they have too small surface area to maintain the uterine cavity. So they are not that much effective. Next is estrogen progesterone therapy. It has been shown that these estrogen progesterone therapy significantly increase the endometrial thickness, endometrial volume, but there is no objective evidence based on RCTs to confirm the efficacy of hormone treatment on the reduction of reformation of intrauterine adhesions. But mostly people are using these estrogen progesterone therapy and they are showing promising results in prevention of intrauterine adhesions. What is the mechanism of action of estrogen? So when we give estrogen, it increases the expression of growth factors. It increases the expression of epidermal growth factors, VEGF, platelet-derived growth factors that further increase the formation of endometrial blood vessels, cause the proliferation of glands and stromal cells. It increases the fibrinolytic enzymes expression, that is MMP9, that further reduce the fibrosis. So it is increasing the vascularity and it is decreasing the fibrosis. Next is techniques to increase the vascular flow to the endometrium. If there is an increased flow to the endometrium, obviously it will grow. So what methods we can use? We can use medications like aspirin, sildenafil, and nitroglycerin to increase the endometrial blood flow and endometrial regeneration. Successful pregnancies after their use, they have been reported. Next is we can use stem cell transplant, but still they are under development. Bone marrow, say we can use stem cells. These stem cells, they differentiate into the endometrial component cells. They secrete VEGF to promote angiogenesis. They activate the proliferation of the endogenous endometrial stem cells, and they cause the restored uterus. But these stem cells, they are still under research. Next, experimental methods are there. First is endometrial transplantation using donor endometrium, fetal membranes, decidua, placenta, but they are under study. Next is role of endometrial growth factor. They are also under study. Fertility and pregnancy outcomes in Asherman syndrome. The overall pregnancy rate following treatment of intrauterine adhesions is approximately 30 to 75%. It is good. Pregnancy and term pregnancy rates, they were significantly higher in those with minimal disease compared with those with severe intrauterine adhesions. There is a huge margin between those with minimal disease and those with severe intrauterine adhesions. The spontaneous abortion rate is not higher than that among women who conceive without a history of intrauterine adhesions. So, abortions इतना नहीं करा रहे हैं as compared to infertility ज़्यादा कराते हैं. Then outcomes after hysteroscopic treatment, most patients with absent menses, they will resume some form of a bleeding pattern after surgery with a rate between 92 to 96%, which is a very good rate. A systematic review, it reports a pregnancy rate of 63% and a live birth rate of 75% after hysteroscopic surgery for intrauterine adhesions. Major complications in pregnancy, they have been reported in women who have undergone hysteroscopic adhesiolysis for Asherman syndrome. Abnormal presentation, it is most commonly reported complication after hysteroscopic treatment. Preterm labor after surgical treatment, it is noted to be as high as 40 to 50%. So these are the complications and that can occur. So take home message is hysteroscopy is the gold standard for diagnosis as well as for the treatment of intrauterine adhesions. Prevention of recurrent adhesions after surgery is essential for a successful treatment. There is still no single modality proven to be unequivocally effective in preventing post-operative adhesion formation after hysteroscopic surgery. Thank you.